Hello, this lecture is about pneumothorax. A pneumothorax is the presence of air in the pleural space leading to a loss of negative intrathoracic pressure. Processes leading to a pneumothorax may be spontaneous, traumatic, or iatrogenic. A spontaneous pneumothorax occurs in the absence of thoracic trauma, and it can be categorized into primary or secondary. So a primary spontaneous pneumothorax, which we'll call a PSP, it develops in an otherwise healthy patient without any underlying disease or trauma. But a secondary spontaneous pneumothorax occurs in the presence of underlying lung disease, but in the absence of trauma. So any kind of pneumothorax may evolve into a tension pneumothorax, in which there's increasing positive pressure in the pleural space caused by air being able to enter but not escape. So potentially life-threatening, a pneumothorax, definitely a tension pneumothorax. Astute assessment skills and prompt intervention are essential. But I want you to know, too, they vary in size. So your clinical presentation, we'll talk about that in a minute. The epidemiology of a pneumothorax is that those primary spontaneous pneumothoraxes occur most frequently in young adults aged 20 to 30. Risk factors can include smoking, cannabis smoking, being male, underlying lung disease, tall stature, thin body habitus, pregnancy, and a family history. Increased incidence in men, look at those numbers, 7.4 to 18 per 100,000 as compared to 1.2 to 6 per 100,000 women. So the pathogenesis is unknown, but thought to be subclinical underlying lung disease. However, for a primary spontaneous pneumothorax, the most common cause is a spontaneous rupture of a pleural apical bleb, and it can be associated with smoking, but it doesn't have to be. Secondary pneumothorax can result from underlying pulmonary disease such as COPD, TB, asthma, lung cancer, cystic fibrosis, or even endometriosis. Penetrating or blunt force trauma can cause a pneumothorax in anyone. And iatrogenic are caused by a medical procedure. Remember, like anything that is accidentally done during a procedure. Most primary spontaneous pneumothoraxes occur at rest. So what's the clinical presentation? As I said earlier, clinical history and physical exam findings really vary depending on the size of the pneumothorax and the volume of air in the pleural space. So include in your history, have you ever had one before, previous pneumothorax, do you smoke, or have you had any trauma? Most common complaint in a clinical presentation is the acute onset of breathlessness. Unilateral pleuritic chest pain can also be a complaint. Secondary pneumothorax have more severe symptoms compared to a primary. So the physical exam should reflect, findings really reflect the size and nature of the pneumothorax. A tension or a large pneumothorax is a medical emergency. A tension or a large pneumothorax may create respiratory distress, diaphoresis, tachycardia, tracheal deviation, and cyanosis. But the diagnostics that need to be included in the primary care office is definitely pulse oximetry. If you're able to pull an ABG, to me they need their, you're thinking this is emergent. So pulse oximetry, chest radiograph, if you have that capability for a PA and lateral, but look at that sensitivity. It's only about 50% sensitive. So remember, that's positive. So if you do have it and it says you have it 50% of the time. Ultrasound is a reliable method, but it's a little more time consuming, but the chest CT is the gold standard. So management and treatment totally, again, depends on size. You can observe a small pneumothorax, and that's all. Can do a needle aspiration, a small bore catheter, chest tube plus pleurodesis or a thoracotomy, and rarely a chest tube plus a sternotomy. Tension pneumothorax requires immediate intervention, that large bore angiocath inserted into the pleural space to release air. Referrals, outpatient care for a small pneumothorax, although I'm going to involve another provider for pneumothorax diagnoses, usually a physician referral or a pulmonology referral. Inpatient care for large pneumothorax or a tension pneumothorax, you're sending the ER. And then primary spontaneous pneumothorax, even if it's small, always referred to a pulmonologist because they recur. So patient and family education. You focus on the cause, prevention and treatment, if at all possible. It is more likely to reoccur in patients with lung disease, so they need to know what to do. Smoking cessation is imperative in anyone, but if someone's had a pneumothorax, it makes it critical. And then they have to understand that there is some activities that increase their risks until they have full resolution, and that would be of a pneumothorax, no matter what size. Avoid air travel, scuba diving, and any activities with trauma. Now, this is an interesting chest x-ray. I hope you can tell which side the pneumothorax is on, because what you're seeing is a deflated lung over here. By looking at your screen, it's on the left. So that's a large pneumothorax. I will tell you a little clinical caveat. My first pneumothorax was actually at ETSU at the University Health Center, and a young, physically fit man ran 6 miles to the clinic because he wanted to get in his daily exercise, and he was just wanted to say, I've been a little breathless lately, but not too bad, and I almost didn't come. And he looked great. In his 20s, looked fantastic. No respiratory distress. His pulse oximeter was, if I remember correctly, a little bit reduced, maybe 95%. However, when I put my stethoscope to his chest, he had no breath sounds on one side. So anyway, chest x-ray revealed almost a complete pneumothorax of one of his lungs, and he ended up being admitted and having a large bore cath placed to release the air because he was really suspect for development of tension pneumothorax. Interesting though, see, that was obviously he had a spontaneous, primary spontaneous pneumothorax, and his symptoms just didn't match. I don't know if he was just in such good shape, if he'd compensated, if it slowly developed. So many questions, but again, this is an important topic, and I'm glad to have it with you. Thank you.